Hello guys, hello family, hello friends. Thank you once more for joining me. I hope you're having a good time and that you are enjoying the content in the channel. This is me trying to do my bit, helping all of us learn, helping students, especially students, because I know that as a medical student, you struggle to understand some lecturers, even though sometimes they have done their best, but sometimes you still struggle to understand and all of that. And also the setup, sometimes it's nicer to just study nicely, have someone teach you while you're sitting at home, at the comfort of your own bedroom or sitting room or wherever. So I really hope that you are enjoying it and that you are learning. And please don't be shy. I want those comments and the likes, and please share the channel to those who need it, to your friends, especially medical students, interns, clinical associate students, clinical associates who are already working, and whoever you think that they would find the channel helpful or refreshing. So today, I hope you're not gonna get tired of seeing or hearing about this word approach. This is an approach. Everything is just an approach, according to me. You want to know, you want an approach to any symptom. You want an approach to any symptom. You want it to be clear in your mind, so that if you have a patient, you know exactly what to do. But if you don't have an approach, if you don't know what to do, it's not clear in your mind, you might have all the knowledge required to diagnose a patient or to save a patient's life, but as long as you don't have an approach, you don't know what to do, what steps to take in terms of your history, your physical examination, investigation, and your management. Like I said, you might have all the information, but if you cannot have an approach, it will always be difficult. So what I want to cover today is an approach to PV bleeding. Approach to PV bleeding. How do we approach a patient with PV bleeding? Okay, so this patient comes in. Obviously, it's a female with PV bleeding. That's the main presenting illness. This lady, as she comes in, the management is going to depend on whether this patient is stable or unstable. Stable or unstable. Unstable. So my approach to this patient is going to depend. Is this patient stable or unstable? Look at this. Pay attention to the fact that I don't really care about history right now. I just know that it's a PV bleeding patient. But whether they are 17 or they are 20 or they are this or they are that, at this point is not important. What is important is, are they stable or they are not stable? Because whether you're gonna resuscitate a patient or not does not really depend on the cause of their PV bleeding. What you want to resuscitate the patient, to bring them back to life if they need resuscitation. So whether they missed a period or not, or whether they've had this before, or whether it's not relevant at this point. What you want is to know, are they stable or are they unstable? And stability or unstable, it means that if they are stable, it means they've got normal. If you use your collar cap, like I said, that this is an approach of medical emergencies. You call a cap, circulation, airway, breathing. So that's your priority. Like I said, it's contrary to ATLS, which is A, B, C, D, and E, and also G, because G is glucose. So it's different. So you want to call a cab. So if you call a cab, the C will tell you that my BP is normal. My pulse is normal. Then our patient is stable. Airway, patient is talking to me. Patient is breathing. I don't have to worry about that. Respiratory rate is normal. So based on this, call a cab. That's when I can say my patient is stable. But if you call a cab this side, it means that you are saying the BP, most likely because it's bleeding, I would assume that it's low, pulse is high. So they've got a tachycardia. Or maybe they might even be in shock. A patient that is in shock, like I said, the history is not relevant there. What you know, it's a female patient that is PV bleeding and is in shock. You start resus. After resus now, you can come back and say, okay, mama, what happened? You start taking the history now, because now you want to find the diagnosis. Resus is not about finding a diagnosis, it's about bringing a patient back to life. And sometimes, examiners, when you talk about a PV bleeding patient and then you start talking about, okay, I'll take history, blah, 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 and then they look at you and say, but do you know that this patient is unstable? You will feel like your exam basically will be over depending who you meet on your exams. But basically, because you need to know, especially if it's an oral exam, you want to know that what kind of patient am I dealing with here? Which means now, if they give you a case scenario, it means you must go through that case scenario and look at the vital signs. Once they say bleeding, look at the vital signs first and decide, is this patient unstable or unstable? If it's unstable, what am I going to do? This one is unstable. So we're going to meet somewhere here with this unstable patient. We're going to meet here. With an unstable patient, what you want to do, you want to start resus. How do you resus? Yes, you will call for help, get everyone involved as you put up two IV lines. Two IV lines, not just two IV lines, but you need to use big cannulas, your green or your gray. You put two IV lines, you put the patient on oxygen. And as you do that, so you want to know, you also take bloods at the same time. The bloods that you want to take, bloods for a bleeding patient, they are never different. You want to take your platelets. Because for a patient to bleed so much that they get into shock, you want to know how are the platelets. You take your platelets, you take your HB, because you want to know, are they anemic? Because they've been bleeding. HB. You take your INR. So those are your basic bloods that you can take. Some people would say take a PT as well. So, and then you give the fluid. So resuscitation in terms of, so you can do a fluid resus, meaning you give, and also you might want to cross-mesh this patient as well. If they are pale, clinically they look pale and they're in shock, you might just wanna cross-mesh that patient and not wait for the HB to come. But if you do a word HB and it's low, then you can quickly do it depends what do you really wanna do, because it depends where you are. If you know that you can get a word HB, then you might wanna do that first before you cross-mesh. But if the patient is pale and you don't have a word HB, you might as well just go on and cross-mesh that patient. So these are the bloods that you would want to take. So, and then you give them fluids there. You do a fluid resus. As you do a fluid resus, there's going to be a point in your resuscitation where you realize that, no, I have been resuscitating the patient. By definition, you shouldn't give more than 3 liters to a patient without giving blood. So by the time you are using 4 liters of blood, 5 liters of blood, by the time you're using 5 liters of normal saline or Ringer's lactate, then it's a sign that maybe fluid resource is not enough for this patient. So consider moving on to a blood product resource like your red cells and your other products, your FFPs and all those things. So don't ever give a patient fluids all the way without getting any look at this. I'm not doing PV exam here or doing any other thing to find out the cause. I'm just doing research here. I will deal with the PV exam later on when I've done my history. What I want is to basically, when you do a resuscitation, you just want to bring the vital signs back to normal. That's it. That's what the resus is. It means that you've got abnormal vital signs that you want to bring back to life. So you give maybe up to 3 liters, 4 liters, but going to 5 liters, because remember, this patient didn't lose fluids, they lost blood. So an ideal way of resuscitating, you give them fluids and then not too much. When you get to, like I'm saying, when you get to about 3 liters, 4 liters, you must start, like we did a cross match here, okay, maybe I need to give this patient blood products, because the more you give fluids, too much fluids, first of all, you might run into pulmonary edema, and also you might run into a situation whereby you are messing up with your clotting factors and diluting your HB further if the patient is anemic. So there's a lot of problems. Maybe I'll do fluids one day and just talk about fluids and their dangers. They are not as harmless as we all wish them to be and all that. So you give them, so now you see your blood pressure picking up, and the blood, they come out, the platelets maybe are normal, the HB maybe it's 8 or 7, maybe you give them 2 units to correct that, and then basically they come out of this situation. This should be enough to take them out of this situation. Like doing these kind of things should be enough. Why do we give oxygen to a patient that is bleeding? The reason why we give oxygen to a patient that is bleeding is because this person might be having few red cells. So we want to make sure that we saturate those few red cells that they have, because when they're bleeding, they lost red cells. So by giving them oxygen, you are maximizing, you are making sure that the red cells that they have, the few that they have, they are well saturated with oxygen to make sure that the organs in the body, they still get oxygen. So that's the reason why you give them that. So let's say after doing this, to make it less complicated, after doing this, the patient becomes normal, they start talking to you, they maintain vitals, the tachycardia improves. Now they become normal. What is that? So they get if they were hypotensive, they become normotensive. If they had a tachycardia, now the pulse becomes normal, and they start talking to you as well. And as much as they might still be bleeding a bit, so now you have stabilized your patient. So now you meet here with this site. Now you have stabilized your patient. If your patient needs a platelet, you transfuse platelets. If the patient needs red cells, you transfuse them. So you have cross-matched your patient, so the blood. And also, if you realize that your patient needs emergency blood, there's nothing wrong going ahead and getting emergency blood. If you do your ward HB and before you can take your bloods. Even if you do your ward HB and it's like the patient has got a HB of 2, 3, you might as well run for the emergency blood and use that blood while you are waiting for the blood that you have cross-matched. And in centers where you cannot cross-match a patient or you cannot transfer the patient at that time, it's a good reason to refer that patient. Because remember, if you keep the patient the whole night with a low HB, they might wake up having a cardiac failure. It's called a high output cardiac failure. It's caused by anemia. So you don't want to keep them without giving them blood if they really don't need blood. Now the patient is stabilized, out of shock, now he's talking. So now you go back, you find out, Mama, what happened? Then they start to tell you, okay, what is important, what you want to know there is on which side of the reproductive years is this woman. So you want to know, their age will tell you. So reproduction status, I don't know what term to put to this, but what you want to know is it someone that is still reproductive? Is it someone that can still fall pregnant, or is it someone that is postmenopausal? So if they are postmenopausal, let's say they are postmenopausal, so now it becomes a postmenopausal bleeding, which on its own has got its own approach. But if they are reproductive, this is what I want to talk about. I'll cover this in my next videos. Let's say they are reproductive. If they are reproductive, so you would have taken the history, LNMP, when was the last time periods, when did the bleeding start, were they clots, you might even want to ask them, were they pregnant, and all those things. But what you want to do, you want to do a beta HCG. Do a beta HCG on this patient. So you have taken your history. And then after taking your history, you examine them. And then as you examine them, so obviously you examine them from head to toe. Record the pallor again if it's there, that they are not in shock anymore. Their blood, their vital signs are there, and the abdomen is whatever that you find on the abdomen, because you're taking your history, right? The history of PV bleeding, passing clots, passing any products, abdominal pains, all those things. So if you find that they are reproductive, so think about pregnancy related. That's why I was making this differentiation. If they are reproductive, think about pregnancy-related problems. So what you want to do is, let's say you do a pregnancy test and it comes back, it's positive. If it's positive, the next thing that you want to, that your history will tell you based on the LNP and all of those things is the weeks. Were they 22? Were they 20, 22 or 24 weeks? 22 or 24 weeks and less, or were they more than 22 weeks or 24? The reason why I'm putting these numbers is that if a patient has got PV bleeding and they are less than 22 weeks, the reason why I'm putting two numbers there is that there are some books that say 22, some say 24. But I would like to believe that it's 22. Anybody can correct me there. So if they are 20, let's say 22, if they are 22 weeks and less, then I'm saying it's a pregnant patient, they have PV bleeding and they are less than 22 weeks. That there you need to think about miscarriages. But if they are PV bleeding, beta HCG is positive, think about antepartum hemorrhage, APH. if they and then in terms of the miscarriages, you want to know the type of the miscarriage that they are having. And this is all based on a clinical examination, because as I take my history and I calculate for you that, okay, by what you are telling me, you're supposed to be around 12 weeks, 13 weeks, 14 weeks, but less than 22. When I go and examine you, I'm going to check, am I having an abortion or a miscarriage, and what type of a miscarriage am I having? The type, you can have a threatened or a threatening miscarriage. You can have an incomplete. You can have a complete, or you can have a missed miscarriage. Those are the types that I know. And the differentiation here is clinical. A patient with a threatening miscarriage this patient will never get to shock. They will have PV bleeding, spotting, but they won't get to shock, because by nature, PV bleeding from a threatening miscarriage is not a lot of blood. So they'll be spotting these ones. They'll be pregnant, they'll be having PV spotting, and the abdomen will be soft and non-tender. And when you examine their PV, doing a PV exam, they will not be actively bleeding, but their pad might have spots of blood. And then their os will be closed. Os closed, very important. No clots, no active bleeding, os is closed. Patient is spotting. And when you do an ultrasound, the fetal heart is still there. If they're at a stage whereby you can see, fetal heart is still there. That's your threatening miscarriage. Management for that: bed rest. They continue taking their treatment, avoid walking long distances, picking up heavy stuff. They just do bed rest and continue with the hematinics. Incomplete miscarriage. This patient has got PV bleeding. They will tell you that I passed clots, and I might have passed, they might have passed also some products, and now they are continuing to bleed, also still passing clots, abdominal pains like a bed, PV, actively bleeding, os is open. Sometimes you can even expel clots there. So it's an incomplete abortion. When you do a scan, you will see there are products that are still left. This patient needs to either be done an MVA or an evac. You will decide where you are and how many weeks there. By definition, an MVA should be done when the patient is less than 12 weeks. If it's more than 12 weeks, they should be done in MVA. So an evac, if they are less than 12 weeks, an MVA suffices, or it's enough, or it's sufficient. But if they are more than 12 weeks, then they should be done in evac, be taken to theater to expel all those clots that are there. If you've got a complete, these patients are the ones that can come in shock. These ones can even come in septic, with septic abortion. These ones, very dangerous, these ones. The ones that have got a complete abortion, they will tell you that, oh, I bled a lot, there was a lot of pains, I saw a baby, I saw products, real products that I could feel and touch and see. However, now all of that is better. I'm just having spotting right now. And when you examine them, os is closed, not actively bleeding, no clots, abdomen is, when you're doing a scan, there's nothing in the uterus. Complete abortion. These ones, what you can do with these ones, if they are pale, you can just do bloods and just correct if they are pale, if they are pale, or maybe if they come in with symptomatic anemia, you manage that. Otherwise, giving them, if they are hypotensive, you can just give them fluids, keep them overnight, discharge the following day, reassure them, and all of that. Missed miscarriage. These are the patients that have the baby is no longer alive inside, but the body has not expelled anything. Because for you to expel, the body needs to take out what is inside, and the uterus must start to contract. Your hormones must get involved to try and take out what is inside the uterus, which is not supposed to be there. So a dead baby is not supposed to be in the mother's uterus. So it's like, now the word, when I think about the word misting, to make it simple for myself, it's a baby that is no longer alive in the abdomen, in the uterus. The baby is no longer alive in the uterus, but the body didn't pick it up that I need to take this, because now it becomes a foreign body. But so the body didn't make any cervical changes, so there's just nothing. So there's no PV bleeding. They might be having a discharge if it's been there for a long time. They might, and when you do an ultrasound, the heartbeat is not there. The baby is not alive. That's a miscarriage. These patients are admitted for what is called IOL, induction of labor. So you induce them, these ones. Like I said, there's what is called septic abortion or septic miscarriage. A septic miscarriage, for me, I don't like putting it there, because to me it's a complication of this. It comes from one of those. You don't just get a septic abortion. So it's a complication. So now it means that you have been having a uterus that has been open for a long time, because you have been passing clots and all those things, and bacteria has found a way to get inside. These patients are normally very sick. They are the patients that might come in shock, both in septic shock and also in hypovolemic shock. They are very dangerous, these ones. You need to take very good care. These ones will need you to take white cells, CRP, and the likes, and start them on antibiotics, admit them. They'll have a tender uterus because of the infection. They're draining pus, foul smelling, and that kind of thing. So you admit this patient and give them antibiotics, and if they're still having products, they are done in evac, normally by a very experienced person, because their uterus is normally, I don't know if I can use the word, because it's septic, it's easy to perforate. It's easy to perforate because it's septic. It's easy to perforate, and you find yourself taking out the bowel through the uterus. So so that's our approach.